going to be here. Great appreciation. بس نعمل البرزنتيشن بعد اذنك. I will talk about lung transplantation, worldwide experience in cystic fibrosis, the outcomes and the advancements. Unfortunately, we didn't have till now lung transplantation program in Egypt. But hopefully the next year will make us make a program for lung transplantation, because we already have thousands of patients, pediatrics and others who are in great need for lung transplantation as a last chance and hope for them. I will talk about history of lung transplantation in brief, the indication and failure and listing of patients of cystic fibrosis to be involved in the program, the pre and post-operative care, complications and contraindication, and last about the performance and the outcome. طبعا حضراتكم تعرفوا اكتر مني ان the main problem in cystic fibrosis in the FCFTR protein. Pulmonary manifestation carries the greatest risk for morbidity and mortality. These infants or young children suffering from recurrent cascades and episodes of recurrent inflammation and infection, ending in bronchitis and destroyed almost lungs, ending in respiratory failure, either type 1 or type 2 respiratory failure. So lung transplantation is the hope for many of these patients with respiratory failure. First, lung transplantation was done in 1963, but it didn't survive more than 18 days because of renal failure. But the very successful lung transplantation was in 1983 as a single lung donated, and the very successful double lung transplantation was in 1986 for an indication of emphysema. With cystic fibrosis, the very successful was also in 1983. First double lung transplanted in a cystic fibrosis patient was in 1988. And after that, indication of cystic fibrosis and lung transplantation is increasingly year after year in many centers all over the world to become the third most common indication for lung transplantation worldwide. What would I expect from a lung transplantation in a patient with cystic fibrosis or whatever the indication? I expect that this patient will have many years survival. The median survival in all indications is 5.7 years. Higher in patient with cystic fibrosis. I would expect patient to live a life with a better quality. He can resume his activity, either going to work or the indoor or outdoor activities. About 4,500 lung transplantation are now performed annually across the world, and the recommendations are to refer your patient with end-stage lung disease as early as possible. Because of a lot of factors, we will need time to complete his workup, which may take up several months or a year to be completed. We should have a strong relation with our patient as a transplant team. We would assess our patient carefully, especially in the psychological aspect. So if we had a patient with a severe pulmonary disease, cystic fibrosis patient, that despite maximizing his medications and caring, he's in a failure, with a risk of more than 50% over the next 2 years of mortality and the likelihood of more than 80% of survival during the next 5 years, we should refer this patient for cystic fibrosis. According to the latest consensus document of Journal of Heart and Lung Transplantation, the broad item, I have a patient with end-stage lung disease with a high risk of mortality. Cystic fibrosis specific criteria for referring this patient is a patient with a declining pulmonary function, FEV1 less than 30% in adults and 40% in children, or better 10% if this patient has a worse prognostic factor like pulmonary hypertension, massive hemoptysis, recurrent exacerbation, recurrent hospital admissions, recurrent need for oxygen support, or a single episode requiring mechanical ventilation. But referral is a decision of cystic fibrosis team, but listing the patient with the waiting list of lung transplantation is a shared decision between the CF team and the lung transplant team. When the patient reaches a level where FE1 is less than 25%, a patient had recurrent episode of massive hemoptysis with failed embolization, requiring one episode of mechanical ventilation, this patient should be listed on the waiting list of lung transplantation. Special recommendation for this patient is a continuous coordination between the CF team and the lung transplant team. I should lower threshold for listing this patient if they are female, if they have bronchial colonization with MDR pathogen like Pseudomonas. This patient should be referred and listed early for lung transplantation. Contraindication for lung transplantation, absolute contraindication associated with a very high risk of post-operative mortality, including a patient that is not willing for transplantation, is not psychologically stable, has a fundamental uncontrolled infection, have other organ severe impairment like liver or kidney or failure, except if I will do for him by organ transplantation. Relative contraindication depends on the experience of the center of lung transplantation, like old age. It's not the case in our cystic fibrosis patient, including mild to moderate liver or renal impairment, mild to moderate ischemic heart disease, and ischemic cardiomyopathy. I selected the recipient, but what about the donor? The donor, I am talking about cadaveric donor. Worldwide, living donor for lung transplantation is almost obsolete, except in Japan. The ideal donor, which is a mechanical ventilation with brain stem death, is a young one from 20 to 45, has a high PF ratio more than 300 or 350, with a low or no smoking history, with a clear lungs, apparently from the chest X-ray, and clear secretion or no secretion when I do bronchoscopy for him. But because of the rarity of donated lung organs, this donor criteria is extended to accept some situation I wouldn't accept in the past, including a low PF ratio, a higher smoking history, a higher age, and a bibasal atelectasis or permanent secretion on bronchoscopy with a treatable projection. In the past, prior to 2005, these lungs were distributed according to the time spent by the cystic fibrosis patient or whatever the patient with lung disease on the waiting list. After 2005, during this period, the waiting list mortality was very high. So after that, allocation score named LAS or lung allocation score was adopted. It implemented a measurement, a ratio between, a balance between the waiting list urgency, how many days or years or months the patient will survive if not transplanted, against the benefit after transplantation, the expected time to live post-transplant. Then the score is from 0 to 100. After implementation of using this score, the average time waiting list decreased, number of transplantation increased, the average LA score for patient underwent lung transplantation increased. It is a computerized system which calculates the data of present pre-transplant and the predicted data of these patients post-transplant, and the higher score represent higher urgency and the greater potential transplant benefit. Lung transplantation as a solid organ transplantation suffer from many obstacles. The major obstacle is the rarity of lungs to be donated. Only 15% of cadaveric donors I can retrieve lungs from them for recipients, unlike liver and renal and also cardiac. I can retrieve liver and kidneys from cadavers up to 88% of all cases. So to expand the donor pool, I could now accept a DCD or donation after cardiac death. I could reduce the size of the donated organ if it is not matching the size of the recipient, especially in cystic fibrosis, young adult or adolescent, I could donate, I could use the cadaveric body for multiple liver transplantation in different patients. I can use what's called the ex vivo lung machine, which is artificial machine, which was developed, I think, from 10 to 15 years ago. It aims to recondition the unconditioned lung taken from a brain-stem patient on mechanical ventilation suffering from ventilator-associated lung injury or ventilator-associated pneumonia outside this patient, and before implanting this lung in the recipient, I would condition the lung using a ventilator and using a machine like ECMO, aiming to obtain a better outcome and expand my donor pool. The pre-transplant evaluation of the patient is a very meticulous and lengthy and complex procedure, needing a comprehensive assessment of this patient, pulmonary, cardiac, nutritional, and psychological, and need a multidisciplinary team and multidisciplinary between the lung transplant and cystic fibrosis team. From my short experience, I got a training at King Faisal Specialized Hospital, which is the only center in our area in Saudi Arabia. This is an example of the very complex and lengthy procedures we did to the patient pre-transplant to be listed, including laboratory tests, including bacteriological testing, full cardiac assessment, full bone assessment, immunological, HLA, blood typing, pulmonary function, and we should see this patient every 3 months in our lung transplant clinic, and every visit this patient is required to do a lot of investigation. Then post-transplant, according to the Cystic Fibrosis Foundation recommendation, this patient would stick to the lung transplant team for life. And I should see him on a regular basis, weekly, during the first 2 months post-transplant, and then after 2 weeks, and then after every month, and then after 3 months for life. And according to the schedule, each visit carries a number of investigations for this patient. These patients also post-transplant, we did for them what we call the surveillance bronchoscopy. It is a bronchoscopy, we did it electively and took a transbronchial lung biopsies from the transplanted lung to detect early and silent rejection. Because the CLAD, what we call the chronic lung allograft dysfunction, is the main limit, the main obstacle for a better survival for lung transplant patients. Patients with lung transplant predicted to live within 5 to 7 years only, unlike liver and renal transplant, because of CLAD or chronic graft rejection. We have two types of chronic rejection. We have what we call obstructive syndrome, BOS, and RAS or restrictive allograft dysfunction. And the incidence is 50% of these patients within 3 or 5 years will develop chronic allograft rejection. Complications including infectious and non-infectious, and the infectious complications are the main hazard in patients with cystic fibrosis, because these patients already have mostly MDR pathogen in their ways, either Pseudomonas or PCC complex or Mycobacterium abscess or Aspergillus, which carries a high risk of recurrence post-transplant and carries a high risk of post-operative morbidity and mortality. Non-infectious complications specific to cystic fibrosis, بنتكلم عن ال GIP complications, the high risk of developing osteoporosis and osteonecrosis with diabetes mellitus, especially if this patient would be long-term or lifelong on steroid therapy as an immunosuppressor post-transplant. In some centers, if they had a young patient with cystic fibrosis suffering from severe respiratory or cardiac failure and on the waiting list of lung transplantation, I could bridge this patient by the help of ECMO until I could offer a lung transplant for these patients. Prognosis for lung transplantation in cystic fibrosis patient is very favorable. The median survival is the longest in comparison to other indications for lung transplantation, like age, unlikely age, and surprisingly lower age or young age here, and female and low FEV1 and pulmonary hypertension, and very high or very low BMI and diabetes and colonization with PSA or PCC are associated with post-transplant mortality. But pre-existent PCC infection, which is a very virulent organism, carries the very high risk or the high stress for post-transplant mortality, and it is a relative or absolute contraindication in some centers to reject this patient colonized with this type of bacteria. So the median survival, as I said, is about 9 years. It is the longest survival among all transplant indications. This study or registry of Toronto Center for Lung Transplantation, which was published in 2020, they transplanted about 1,885 lungs. 19% was in cystic fibrosis patient. They found that the mortality rate was higher in the PCC bacteria complex infection, positive against the PCC negative in cystic fibrosis patients. The new era of the HAMD or the highly effective modulator therapies كان ليها امباكت كبير على زراعه الرئه في البيشنت بتاعت السيستيك فايبروزس. لقينا ان الايدج بتاع البيشنت اللي احتاجوا ترانسبلانت في السيستيك فايبروزس كانوا اكبر. البرسنت بتاعت البيدياتريكس اللي بيحتاجوا لانج ترانسبلانتيشن قلت against البرسنت اوف ادلت والايرلي ادلت والادلت اللي احتاجوا لانج ترانسبلانتيشن. ده لان الجود كير والريفولوشن اللي حصلت بعد الديفلوبمنت اوف ذيس دراجز حسنت الاوتكم جدا وزودت اللايف سبان وزودت الاف اي بي 1 او حسنت الاف اي بي 1 والبادي ماس اندكس وقللت الفريكونسي بتاعت الاكسسربيشن in cystic fibrosis patients. كمان bridging this patient on ECMO until offering the lung transplantation. All of this including improving the outcome of lung transplantation in cystic fibrosis and raising the age of patient needing transplantation. A debatable question whether or not to continue on our modulator therapies post-transplant. Previously, theory كانت بتقول the primary outcome of these drugs is to improve the FEV1 in this patient pre-transplant. And after transplant, I completely changed my lung. I have now a lung with a normal FEV1. So no need for chemotherapy post-transplant. But recent studies demonstrated that the use of this highly effective modulator therapy even after transplantation helped to manage the non-pulmonary manifestation, improving the dietary situation of this patient, improving the MI, BMI, improving the whole and general condition of the patient, and consequently improving the outcome and the survival of this patient. But a paper released in December 2004 stating that indication of cystic fibrosis patient and lung transplantation is dramatically declined over the past years owing to the evolution of the new drugs which the triple therapy which will take took FDA approval in 2019. In 2022, indication of cystic fibrosis patient for lung transplantation declined to only 1%. ده كان رقم غريب جدا زي ما حضراتكم شايفين. Over the past years, cystic fibrosis account for about 15% of all transplanted patients, but in 2022 it was only 1%. كان ليا الحظ ان اشارك في كتابه جزء من الريجستري بتاع السعوديه. Cystic fibrosis was the third most common indication for lung transplantation in our center. وكان ال 5 years و 7 years 5 years survival for this patient was above 70%. Lastly, lung transplantation remains a life-extending option in cystic fibrosis patients despite the revolution of therapy. Outcomes have significantly improved. Early referral and careful evaluation are keys for better outcome in this patient, and we should always need a multidisciplinary approach to treat the cystic fibrosis and lung transplantation. Thank you.
Thank you, Professor Mohamed. شكرا لمشاركتكم والاستضافة الأخ العيني. شكرا for the question. أنا كنت بس عايزة أسأل هو الترانسبلانتيشن عايز الباثولوجي موجود يعني فهل حضرتك تقول السرفايفل بتاعه كان أقل من الأذر إنديكيشن؟ هل علشان الحاجات الإكس بالمونري ولا عشان الباثولوجي بيرجع تاني ولا مفيش لونج تيرم ستاديز؟
قصد حضرتك ان البيشنت
الباثولوجي لسه موجود يعني فالنيو لانج العيان مش على الفنتليتر قبل كده هل في ستاديز بتقول لو هو لسه قبل الفنتليتر هل بيرجع الباثولوجي من قد ايه؟
لا recurrence of the primary disease post-lung transplantation in general very rare. It reported cases including LAM, PLCH, sarcoidosis. بس مفيش any reported case of recurrent cystic fibrosis in the new transplanted lung. Median survival يمكن عشان البيشنت دول هم اصغر بيشنتس كل الانديكيشنز اللي احتاجت lung transplantation. البيشنت ده حضرتك من هو مثلا مش عارف حضرتك بتتابعوه من سنه ولا حاجه فالبيشنت ده بيبقى ريسيفنج جود كير من وهو سنه غير البيشنت الثانيه اللي ممكن تبريزنت ليه في البلمونولوجي يعني. العفو.